All right, my great pleasure to introduce Ian Brown as our speaker for Grand Rounds today, focusing on one of his true passions and love is the inflammatory response. Ian is a Bay Area native, I believe, grew up in Oakland. Did you not? No? You were a Chicago native. No. Okay, well, that explains. So he ended up at Stanford for his undergraduate degree in biology, but then went back to south side of Chicago for his PhD in immunology, as well as his MD in medicine, both at the University of Chicago. But apparently the love of Stanford was, and the Bay Area grew too much, either that or the cold winters this time of year. And he came back to the Bay Area to UCSF for his residency. And then as his penultimate move, and then finally here for his ultimate move as a Trauma Surgical Critical Care Fellowship at UCDAVIS, where we've been fortunate to have him stay. He's had a very illustrious early career in the inflammatory response, receiving the two probably most prestigious awards available for young faculty, one from the AAST, the Trauma Society, and one from the American Surgical Association, both to support his research on the inflammatory response. But before I have him come up and talk about that, I also want to acknowledge that he's been a great advocate of community violence prevention programs, active participant in the gun violence prevention program, active participant in trying to incorporate the community and gang-related violence and minimize that effect, and been a great supporter and active participant in those activities here within the university and its surrounding community. So a great community partner we have with Ian Brown with our community as well. So Ian, why don't you come forward and educate us on P-Selectin.
Good morning, everybody. Thank you for the introduction, Dr. Jerkovich. The only other person that I've ever heard regularly use the word penultimate was my father, who couldn't ever hear me speak like this, but it was a really nice flashback. So I'll be talking today about one of our research focuses, or foci, P-Selectin-Dependent Pulmonary Arterial Thrombosis. I have no relevant disclosures with regard to this topic. So first, I just want to give a little bit of background as to sort of why we're interested in it at all. So I'm interested sort of in the axis that intersects between inflammation and coagulation. And inside of blood vessels, this axis includes sort of the concepts of what we call immunothrombosis. And so what is that? And I'll get into that a little bit in the next slide, but the idea is pretty simple. So evolution is very economical, right? And your body would know in any kind of multicellular organism that if there's a situation where you need to stop something from bleeding, there's probably also a situation where you need to wall off pathogens as well. So it makes sense that inflammation and coagulation would be coupled together. And in fact, though they teach it to you for simplicity's sake in med school as two separate things, the two things are actually so intertwined that in my mind at least, I don't actually separate the two. I see it all as one continuous process with local components and systemic components, and as a result of that, there are local and systemic benefits and consequences. So there's a ton of crosstalk and recruitment that occurs as a result of coagulation, and so that brings about inflammation. And then just as I mentioned before, the teleology of it just makes sense. Everything sort of evolutionarily is sort of built to be economical. And if it doesn't seem to be economical, that's just because you probably don't see it. And that brings me to just one little aside that I just want to mention. A lot of times when we think about things such as the topic we'll be talking about today, we think about sort of maladaptive responses. And maladaptive is a funny term And often it just means that we don't actually understand what the adaptive part of it was, why it made sense for it to happen. And so when you're looking at the overall problem, you have to consider the whole limitations and understand that you can't see what you don't understand. And you start from that place, and then you work yourself towards the problem. So I'll start with a case, and this will be sort of a typical case we see. So we'll be talking particularly about pulmonary arterial thrombosis, which is not super common, but when we do see it, it tends to be very problematic in terms of management. So here we have a 47-year-old man who's brought in by ambulance after a high-speed motorcycle crash. He's helmeted. He got ejected and thrown. He comes in with, I don't know why that thing keeps coming down, with subdural hematoma, multiple rib fractures, you've seen it before, bilateral pulmonary contusions, and a solid organ injury like a spleen, or in this case, a grade 4 liver laceration and pelvic fracture. He's intubated initially for GCS, and then you get him to the scanner after you've got him all stabilized, and what you see on the imaging, oftentimes even as early as the first CT scan, is subsegmental or segmental pulmonary emboli. Initially, he seems to be doing okay. He's oxygenating, but then you get him to the ICU, you resuscitate him, and over time, his pulmonary contusions blossom. He's got worsening oxygenation and ventilation. He's requiring ARDS-net vent strategy. And you're concerned because you're realizing that you need every bit of oxygenation and ventilation because you're trying to deal with this really bad TBI that he's got, and you've got these oxygen targets that you're trying to hit. And so you're thinking about these PEs that he's also got in addition to these bad pulmonary contusions. And what are you going to do about them? Any thoughts? Trying to make it interactive. So when you're thinking about this, you might have said initially, oh, well, they're subsegmental or segmental, and we don't want to treat them because we have TBI and a liver laceration, so we don't want to give therapeutic anticoagulation to a brand new fresh trauma because we don't want to kill them from having them hemorrhage either intracranially or from their liver. But you're starting to need every bit of oxygenation that you can get, so you're stuck, right? And this is not like something where you can say, oh, well, we'll just sort of ride it out and put in an IVC filter. Why? We'll get to that in a second. But your problem is that your PEs are already there. And you're stuck because the treatment is just as dangerous as the pathology that you're dealing with. So, like I said, so this is not a common problem, but when it happens, it's a real rock and a hard place type situation. It gets even worse if over time you see that the heart seems to be struggling a little bit and you're having some cardiopulmonary problems, and then you get that EKG and you see a little bit of right heart strain, and it's even worse because now you're really pushed towards the anticoagulation, but you're really stuck. So, like I said, it's not super common, but thoracic trauma is fairly common, so the potential for it is always there. In patients that actually die, 20 to 50% of the annual 200,000 deaths in trauma have a contribution from blunt thoracic trauma. And interestingly enough, patients that have blunt thoracic trauma with significant injury are twice as likely to actually have a pulmonary thromboembolic event, with a 42% incidence for patients that have an abbreviated injury score for thoracic injury of 3 or greater. And what's really notable about these is that the presentation of these events is actually quite early, like within hours. Notably, often within the first 4 days, but often even within the first 6 hours. So when you think about that, does that sound like an embolic event? For an embolic event to occur, you'd have to have something in your deep veins that actually forms and then begins its fibrinolysis process and is actually sufficiently established enough to break down and then embolize and then end up in a dangerous place. That typically, in most patients, it's on the order of weeks and not really on the order of hours. And so this led us to sort of the suspicion that this is not actually an embolic event, but rather an in situ thrombotic event. So why do we care? If it's a thrombotic event or an embolic event, what's the treatment? It's the same. You're either going to anticoagulate or you're not. So does it actually matter? Well, it does, for some of the reasons that we presented. So when you contrast the idea of a pulmonary embolism versus pulmonary arterial thrombotic event, the presentation is different, right? So arterial thrombosis would be expected to occur earlier, right? Which gives you a problem because that means that the treatment is riskier. When you have a later event like a classical pulmonary embolus, you tend to have stabilized the initial hemorrhage, so you can actually more safely proceed with anticoagulation. Additionally, sort of the actual biology that's going on at the site of the lesion is different. In the setting of pulmonary arterial thrombosis, you're actually having a local endothelial activation with recruitment, with binding of platelets and inflammatory cells. With an embolic event, at least initially, you don't have that. You just have something that floats until it gets stuck by a pipe that's too narrow. Now later, you might get that as a result of vascular occlusion if the embolus is big enough, because then the surrounding tissue will get inflamed. But the initial injury is very different. Treatment, as we said, anticoagulation. For a PE, in many cases, you can give an IVC filter. But if it's in a thrombotic event, obviously, because there's no embolism, an IVC filter would be useless because there's nothing coming from the deep vein. It's all at the site of the injury. And then prevention. So to prevent DVTs, we use sequential compression devices and we give prophylactic dose. That's not relevant really for pulmonary arterial thrombosis because the event occurs so early on that it's not really prevention you're doing, it's already treatment. Long-term consequences, chronic issues. So in this regard, there's not very much known. For the most part, when we think about PEs even, we just think about the acute effects. However, there are rare conditions, one notably chronic thromboembolic pulmonary hypertension, that can be a long-term consequence of severe PEs. That's a situation where basically you get vascular remodeling and hypertrophy, and it ends up basically resulting in small vessel disease with pulmonary hypertension as the clots from the PE don't fully resolve and actually transform more into more of a plaque-like pathology. Does that happen in both situations? Probably, but it's one of those things where in medicine we tend to only see the things that we notice clinically, and probably on a subclinical level the vascular remodeling is probably much more common. But if we don't see it or if it doesn't make a big impact, we probably don't notice it. The cumulative effect is probably there, but again, you don't know it's there if you don't really look for it. And then finally, quality improvement tracking. I include this actually just because it's just something to think about. So when we think about quality improvement measures and benchmarks, one of the things that we look at is your PE rate, right? Because we're always looking to lower that rate because we think of them as a preventable complication. A pulmonary arterial thrombosis is considered as a PE classically just because our evolution of the definition has not caught up with the times. And so this takes a non-preventable event and lumps it in with a preventable event and sort of scores it against you and against your benchmarkings. And that has sort of some, not on the individual patient level, but sort of as you look at the nature of your hospital, that sort of hurts the way that the hospital is evaluated. Perhaps in an unfair way, and that may have some consequences. Oh, see, you guys did me crazy. There used to be a clock back there, but they turned it off, and I was trying to keep up. Outstanding. Okay, so we just talked about sort of why we think we care about this pulmonary arterial thrombosis versus PE. So then how do we study it? Well, it turns out that the idea of it being a thrombotic event and not an embolic event is a fairly new idea. So we had to develop a model to even study it at all, because nobody had really looked at it yet, and people hadn't been sort of motivated because they hadn't considered the significance of it. So we developed our own. Couple considerations in the model development, just for you to think about for your own future model development, all my scientists to come. We use a small model mouse system. Why do we do that? One, because it's cheap. Two, because genetically we can study all the contributions in the various proteins, and we can use knockouts and things like that. It makes it just really a nice tool that's also very cost effective. There are some pros and cons to it. One, people always question the relevance of a small animal model when you're trying to translate it up to a big animal model. But for the most part, a lot of the biology is the same. The other thing is when you try to injure a mouse, they can't quite take the hit that you and I can take, even on a pound-for-pound level. So the amount of energy that we can transfer into making that mouse have an injury without being killed is a very narrow window. And so that sort of limits what we see. But a positive on that regard, mice, because of the way their bones are made, their bones are very flexible, like that of a child. And you all know that have dealt with pediatric trauma, that you can have terrible lung injury on the inside without much in the way of injury or appearance on the outside, just because the ribs are so flexible that they'll compress the lungs and cause the pulmonary injury without the fractures, and mice sort of do that. So back to the model. It's a simple lateral weight drop model where we give a defined amount of energy to the mouse, and that transfers in and develops the pulmonary contusion, which we score by the amount of hemorrhage we see, the alveolar thickening, and the lymphocyte infiltration. It's fairly reproducible. We were able to calculate the amount of energy transferred, and we found that it was quite effective. And so that tells us what happens in the lung parenchyma standpoint. And as expected, just to sort of dot the I's and cross the T's on that, we see a vigorous inflammatory type 1 response for the most part with leukocyte infiltration and recruitment. We see cytokine and chemokine upregulation to bring in more of the innate immune response with MCP1, tumor necrosis factor, and IL-12. Initially, we see the typical innate response followed by later on the T lymphocyte infiltration. But what was important for our perspective is that we actually see the clot formation, the actual thrombosis. And so what we wanted to do there was we wanted to use our model and then take tissue from the lungs and then do immunofluorescence and look for the fibrin deposition to show that, in fact, in the vessels that were relevant, which for us would be sort of the analogous size vessels in a mouse to the segmental and subsegmental size of pulmonary arteries, that we saw fibrin deposition. And as you see there, when we look at the sham uninjured mice, we don't see any fibrin, but when we do have the thoracic trauma, we see a nice outline of the vessel as the fibrin completely surrounds the lumen. Very rarely do we ever see full occlusion. That's sort of one of the downsides of the model, in that in order to get sort of that amount of energy, we would probably end up killing the mouse. But we do see a good fibrin deposition. So we saw the process that we wanted to see, and so then we wanted to take it to the next level and see kind of what were the mechanistic activities that had to occur to make it happen. And what we believed is that, unlike a PE, where a big hunk of clot just sort of lodges in there, this was an active process that would require endothelial activation. And this activation would be localized to our target area, and it would interact with the things that we needed it to interact with, the things that form clot. So A particular sort of potential culprit that we considered was P-selectin. Why? P-selectin is a cell adhesion molecule, means that it is sort of upregulated on the surface of endothelial cells in the setting of activation after being stored. And it is used to recruit platelets and leukocytes and help with the process of the rolling and stopping and diapedesis to bring the leukocytes in from the lumen to the interstitium and into the parenchyma of the tissues. It is a stored protein, meaning that the body likes to, or the cells like to keep it sort of ready on hand so that as soon as they need it, it immediately comes out. So your body keeps it in the places you might actually predict. So in the endothelial cells, it's stored in what's called a Weber pallid body, and it just sits there. And then at the site of, once the endothelial cell is activated, that Weber pallid body fuses with the cell surface, and then the P-selectin is present. And a platelet sits in what's called an alpha granule, which is released as the platelet is activated, and that sort of facilitates platelet aggregation and recruitment of other leukocytes to form these little aggregates of platelets and leukocytes. It binds to a protein called P-selectin glycoprotein ligand, which is present on platelets and leukocytes. Also of note, and I'll mention that now because it will come up later, not only is it bound to the cell surface of endothelial cells and platelets, but it actually gets cleaved at some points, primarily by the platelets, but also by the endothelial cells to some degree. And then you end up with soluble dimerized activated P-selectin in solution. So we hypothesized that the endothelial activation and P-selectin expression would be the promoter of our in situ pulmonary arterial thrombosis in our blunt thoracic trauma Murine model. So what we did was we set up our model again, and we had our injury, and then we did immunofluorescence staining looking for the P-selectin. In the first box, what you see is an animal that's not injured. The cells are identified by their staining with DAPI, which is something that we use to just identify cells. And then what you can see in the setting of injury is that whole endothelial outline sort of highlighted by the red, which is the P-selectin staining that we see. So in fact, yeah, it was there. So it's like when you're investigating a crime, first thing you need to know is if they had an alibi, and the P-selectin does not have an alibi because it's right at the scene of the crime. So that's pretty good. And this, just to highlight this, in fact, the P-selectin was right there at the site of our injury in the vessels that we were most interested in. Now, P-selectin is not, of course, the only cell adhesion molecule that's present. And so we wanted to look at other cell adhesion molecules that were present. Turns out that in the mouse and possibly in the human as well, the distribution of cell adhesion molecules is such that they're not all in the same numbers in the same place in different vessels. You want the slightly larger vessels to have the molecules that slow down the leukocytes, and then the smaller vessels to have the cell adhesion molecules that actually facilitate the leukocytes coming out of the lumen and into the tissue. So proteins like ICAM1 would be found potentially in smaller vessels, and P-selectin would be found in sort of the mid-sized vessels. And in fact, in our injury, when we looked at the vessels that we were interested in, they had low ICAM1 expression, and they had high P-selectin expression at the time of injury, just as we anticipated. So our next question then was, we have a potential culprit. Is it in the pathway, and can we actually block the thrombosis reaction from occurring if we inhibit the P-selectin? So how will we do this? Well, we needed to find some sort of molecule that would be able to inhibit P-selectin from doing its thing. And so one of the more common tools that we use in this kind of work, obviously, is a monoclonal antibody. Monoclonal antibodies will bind specific reagents, and in this case we have one that's specific for P-selectin and actually inhibits its activity. I actually asked a question about monoclonal antibodies earlier, and just want to point out that monoclonal antibodies intrinsically can be a little bit immunosuppressive in several ways. One is the fact that it competes with the home antibodies for binding during the selection process when your own B cells are trying to figure out which antibody sticks the best to the pathogen. And then the other is because the bottom portion, the Fc receptor portion of the antibody actually inhibits B cell activation. However, when you're going against a self-antigen like P-selectin, a protein that's actually made by your body, it's not competing against its own B cells to make anything, so the likelihood of it being immunosuppressive in this setting is pretty low. So what we did was we took our animals and we gave them either the monoclonal antibody against P-selectin, or we gave them a control antibody, which was the same isotype of antibody as the one that we were using against P-selectin. And then we injured the mouse. In this case, we did the administration of the antibody before the injury. We have also subsequently done it after the injury, and we're still doing ongoing research doing it after the injury. But what we saw, and this is the real take-home message here, is that we'll start with the control panel first. I can do it here. So in an uninjured animal that receives just the isotype control, you just see a regular vessel with very little binding. However, when you do stain for P-selectin expression after the injury, if there's an isotype control antibody, you see that the vessel is completely surrounded actually, sorry, this is staining for fibrin. You see that the fibrin is present and that the thrombosis has actually occurred. And that occurs both at the side of the lung that's on the side of the injury and on the opposite side of the animal as well. When we use our blocking antibody that's specific for P-selectin, we don't see much of that fibrin deposition at all. The blockade of the P-selectin by antibody actually prevents the clot from forming. So you don't get that thrombotic event, which is pretty neat, at least in the acute setting. I should also mention too, which I should have mentioned before, when we do this injury, one of the things that you have to rule out is that you don't cause any cardiac injury, just because that can have all sorts of effects if the injury is not specific to the lung tissue. And so to investigate that, we also looked at troponins and cardiac enzymes and proteins and showed that there was no leakage. And actually looking at cardiac tissue from the animals, we did what's called tunnel staining to show if the cells are viable. And we saw no evidence at all of any cardiac injury. The injury is just through the lung tissue. So what we're seeing basically is this thrombosis event, which appears to be P-Selectin-dependent. That's just the first part of the story, though, because as we talked about before, the P-selectin seems to be coming from several different compartments. Is the P-selectin from the platelet? Is the P-selectin from the endothelial cell? Is it from both? Is it the soluble P-selectin? And what's relevant? And what do we need to block? And does it matter? We know that there's the soluble P-selectin in our model because there's a significant increase in the levels after the injury. There has been some investigation, particularly in cardiothoracic research, as to whether or not soluble P-selectin has any role in contributing to pathology, or if it's just sort of a marker that correlates with injury and doesn't necessarily contribute to the injury. And that's extremely controversial. We looked in our model to see basically if it could potentially play a role. And one of the ways that we did that was we actually gave the animals the injury, but then we also gave them soluble P-selectin to see what it would actually do to the injury, if it would make it worse or not have any effect at all. And so after the injury, when we stained for fibrin, with our control protein that wasn't the P-selectin, basically. It's just, it's sort of matched weight and things. We do see the fibrin deposition. And then when we give actual soluble P-selectin, we actually see full occlusion of the vessel, suggesting that soluble P-selectin can potentially contribute to the pathology we see, that the levels might actually matter. Now, this is not conclusive in any way, and it doesn't show that this is what happens naturally in vivo. This was sort of artificially done. But it shows that it is potentially possible. Now, one of the actual more interesting findings of this was actually one of the controls. So if you look in this panel here, this is a soluble P-selectin that's given to an animal that's not injured. And what you see there is no fibrin deposition. And why is that interesting? Well, it tells us that you have to more likely have a local injury present for the soluble P-selectin to be relevant at all. And that soluble P-selectin, even if it's activated, it basically can't hurt the normal, uninjured, unactivated endothelial cells. So we thought that that was pretty important and neat. So we have a potential intervention. We know that we can stop the pulmonary arterial thrombosis event from occurring. At least in theory we can do it. The question, but that brings about several questions. When to treat is the first set of questions. So one, if these are subsegmental and segmental, do we need to treat them at all? That's a question for that's undergoing a lot of research right now. However, as I mentioned in our previous case, you do have these cases where you're sort of stuck between a rock and a hard place, where even though it's a segmental or a subsegmental PE, you feel the need to anticoagulate just because you have other extenuating circumstances that are sort of pushing you in that direction. Two, with respect to when to treat, like what time can you treat? Is blockading the P-selectin 6 hours after the injury too late to have any effect, or is it still okay? And that depends on the natural history of the thrombosis, which we don't actually know. And so the natural history of a pathology is a very important question, and you have to understand it. And because nobody really had classified pulmonary arterial thrombosis as its own thing before, no one had ever really thought to investigate the natural history of this event. So basically, how does it start? How long does it propagate for? How long does it stabilize for? And what is the natural progression of its resolution? This is an unanswered question at this point. To some extent with PEs, we sort of guess and we give people 3 months of treatment, right? That's sort of the standard, right? In many cases, we give them anticoagulation. But this is a very different injury than a PE because it starts with an endothelial injury. So the resolution might be very different than that. Also, it's not like the standard treatment for PE resolution is extremely effective anyway, because if you look sort of on the microscopic level, there's a study that was done by scintigraphy and right heart catheterization that suggests that as many as 50% of major PEs don't completely resolve with the standard 3 months of treatment. That's resolution in terms of removal of the clot, but not resolution in terms of clinically being able to function as a patient and having symptoms from it. Important distinction. Next set of questions would be how to treat. Again, the traditional treatment, if you were going to do any treatment for this, would be anticoagulation. But we talked about the risks of anticoagulation because these present early in patients where hemorrhage is still a risk. And is anticoagulation dangerous, or is there a possibility that this alternative treatment, this P-selective blockade, is safer because it doesn't carry the same risks of anticoagulation? And that's sort of the promise that we wanted to investigate to see if this gave us a better opportunity. And then third, risk of treatment. I'll start with the two most obvious. If you're blocking P-selectin, I mean, it still is a protein that engages platelets. So if you disrupt that, are you going to stop your platelet plug from forming, and then you're still going to have a similar risk of bleeding that you had before, or will the redundancy of other cell adhesion molecules allow you to just block that particular event in that particular space in the pulmonary arterial vasculature without compromising overall your bleeding risk for the whole organism. And then finally, if you're blocking something that engages leukocytes, does that put you at increased risk for infection? So that's the consideration. And then when you want to actually, just to go a little bit beyond this slide, if you really want to think about it, does blockade of P-selectin influence the way the vessel heals after it's all over? Because healing is a process that's active and requires engagement of leukocytes and migration of those things and macrophages and other cells. And by disrupting this, does it actually affect your long-term outcome? But we started, like most clinicians, just looking at the acute problem first, because we figure it's always easier to treat a live patient than a dead one, right? That's always been the trauma mantra. So to start answering some of those questions, one of the first things that we looked at was bleeding. Why? Because if you still have a bleeding risk, then you haven't really done any better than heparin anyway. So then there's not a whole lot of point in going further. So one of the first things that we did was we looked at sort of traditional markers of coagulation, and we saw what P-selectin blockade did to the blood of animals who had received that kind of blockade. We did this in animals both that were injured and animals that were not injured. Reason being that overall the systemic coagulation sort of changes in the setting of massive injury relative to what its baseline is. Things get activated, proteins do their thing. And what we noticed actually was that our P-selectin blockade did not really particularly change the partial thromboplastin time or the prothrombin time with respect to after injury or in the absence of injury. In one of our control groups, of course, we see that the treatment dose, or what would be the equivalent of a treatment dose heparin, actually raises the partial thromboplastin time as you might expect. So we thought, okay, well that's decent. The prothrombin time was increased to some extent. And we thought that might sort of correspond with fibrinogen consumption, but the partial thromboplastin time was pretty normal. So next we took that finding, and we wanted to look sort of at a more active measure, and that would be viscoelastic properties of clot. Many of you are familiar with ROTIM or TAG and things of that nature. So clotting time is basically the time it's the latency time between the initial start of the reaction and the time that you actually first see formation of clot products. And then the clot formation time is the time once you see the initiation of clot products to the formation of a 20 millimeter clot in your device. And then the rate of that is called the alpha angle. So the clot forming time and the alpha angle tell you basically once you get the reaction started, how fast is it going. And then the maximal clot firmness is a measure of the strength of your clot. And when we looked at our P-selectin blockade, we saw no systemic compromise with respect to the rate of clot formation systemically and the strength of the clot that we got. So that was a very positive finding as well. It didn't completely show us like a dominant superiority over a treatment dose heparin. And so one of the things that we wanted to do next was sort of put it to a real test. One of the injuries that you would most worry about in the setting of this would be some sort of combined injury where you have TBI and a lung injury, right? Because then if you wanted to anticoagulate the patient, that's when your bleeding risk would be like pretty prohibitive. And so what we did was we took a cortical contusion impactor, which is a small device that gives you a reproducible brain parenchymal injury with some degree of hemorrhage. Now, to be fair, a criticism of the cortical contusion impactor model would be that it doesn't create what we see in trauma a lot. You don't get a subdural hematoma or an epidural hematoma with it. You get a parenchymal hematoma, like an IPH. And so the bleeding risk of that is not going to be quite the same as some of the bleeding that we consider. So it's not completely ideal, but nobody has yet developed a model of subdural hematoma with actual active bleeding in a mouse. They simulate it basically by injecting blood into the space, and that's not active bleeding, so it doesn't help us. That being said, we basically gave the mice TBI with our treatment versus high-dose heparin, which would be analogous to therapeutic dose, low-dose heparin, which would be the sort of scaled-down analogy of treatment, prophylactic dose heparin or saline. And when we gave those, what we didn't see was any significant increase in bleeding. Again, we still haven't been able to demonstrate that it's markedly superior to heparin, but it was sort of an interesting test. And I think that a real test would be in a larger animal model where we could actually see what happens with an actual epidural or subdural hematoma. But the intraparenchymal hematoma is probably not going to take us there, just to be critical of my own data, breaking the rules. So where do we go from there? So that data sort of gave us an overall beginning of the picture of what happens in the acute setting. There's still a lot of steps that we're sort of actively working on completing. One is we talked about defining the window of treatment, so knowing how late you can give the antibody and still prevent the formation of the pulmonary arterial thrombosis. And so the way that we are in the process of doing that is we just injure the mice and then we give the antibody later and later and later. And it still works at 15 minutes out, but we need to get it analogous to sort of the transit time from the scene of the accident to the trauma bay, and then even go further. We also don't know how long we need to treat for, and we are working on getting an idea of how long it takes before that P-Selectin expression in the lumen actually goes down to the point that treating with the antibody should no longer have any role at all, right? So how long do they need to be blocked for? And sort of in the setting of doing that experiment, that took us to a new consideration. So when we go beyond the acute injury and we start thinking about resolution and we start thinking about the potential consequences of pulmonary arterial thrombosis and whether or not we were able to treat it or not, what actually happens in that setting. So this brings us to the consideration of resolution versus incomplete resolution. As I mentioned before, even with classical PEs, we don't always see complete resolution of the pulmonary emboli over time, at least in the way that we studied it. Does this have a clinical significance? In most patients, probably not a readily apparent one, but in some patients, it does actually have an outcome. And then probably in the ones that we don't think that it matters in, they're probably not running the 6-minute mile anymore that they used to, right? Because it sort of manifests in small ways. It takes them back down. So not only do you not have the clot resolving, but then you also have the potential for the vasculature phenotypically changing, so remodeling. So after injuries like this, you get sort of this potential for plaque formation almost. You get sort of medial thickening and hypertrophy of the musculature in the media. And then you also have this potential for this sort of plaque formation where you get sort of fibrin that gets stuck there. And if you have enough of that distributed widely enough, particularly in the small vasculature, in a small subset, that will sort of develop into pulmonary hypertension, or it'll sow the seeds for it. So that condition is called chronic thromboembolic pulmonary hypertension, CTEPH. How many people have heard of that? Just show of hands. Okay. Couple, yeah, all right. Bias on the thoracic surgeons because they probably would know about it a little bit more. They probably see it. So it's not super common. I think what we see in the United States is about 5,000 annual new cases. But as I mentioned earlier, incidence of CTEPH after symptomatic acute pulmonary embolism, as confirmed by right heart catheterization, is reported to range from 0.4 to 6.2%. It's a situation that's not super common, but when it is present, it'd be probably really hard to treat. So it'd be something that you want to get ahead of early rather than late. And then just to show you a little bit of sort of what that pathology looks like, this is an image that was borrowed from the European Respiratory Review. And what you see here is a vessel that's been recanalized over time after it had been occluded. And you can imagine that with the vessel lumen now being these small little bits, you're going to result in high pressures as that similar blood volume is trying to get through that really tight space. You're going to see additional formation of musculature in the arterioles. You're going to see fibrosis. You're going to see these lesions basically that look like organized plaque, basically. So the clot basically changes from the standard red clot of platelets that you see with a PE to this organized yellow clot with leukocytes in there and fibrin and elastin and other proteins that have been deposited to make it a little bit more organized, even sometimes calcium. And then you'll see these bands and webs that are present in there as it organizes. And so basically, at that point, it's extremely problematic. It's in small vessels. There's probably not a whole lot that I am aware of that you can do for it. Maybe others may know, but it's one of those things that you want to get that horse before it gets out of the barn. So we wanted to see if, in fact, we had inadvertently created a model that would allow us to look at processes of vascular remodeling and even that clot formation sort of long term, just because that's not something that's super common either. So there are animal models of vascular injury where they do various things, like, for example, they'll strip the inside of the intima with a wire or something and then look and see how that vessel will reform, or they'll do angioplasty on it and see what happens. And that's analogous to studying what we treat. But there's not really any models where you are doing blunt thoracic trauma and then developing the concomitant vascular injury and able to study the natural history of that lesion in that setting rather than the iatrogenic type setting. So that actually makes what we did there potentially a little bit novel if we can show that in fact it actually happens. So I bring back this little picture that we showed earlier today, and I sort of snuck this in there, and I asked you to consider this. And one of the things, what we think that is, and we've been working on sort of double staining it, is that's actually smooth muscle that has P-Selectin staining positively on it. Now, why would P-Selectin be present on vascular smooth muscle when I told you that it's expressed by platelets and endothelial cells? The real answer for that is, I think, still up in the air. There's a lot of different theories. Some people believe that it is part of the healing process and that sort of endothelial cells migrate in and then sort of redifferentiate to form vascular smooth muscle in areas where the lumen integrity has been compromised. And so then as they're transforming, they're still capable of expressing that P-selectin. Other people think it's inducible. And I think that there's strong evidence in some of those areas, but the jury's sort of still out. What I find fascinating about this picture is that it's in 24 hours, and I haven't completely been able to convince myself that redifferentiation can occur in a 24-hour period. So I'm a little skeptical. That being said, whether or not it happens, that P-selectin expression on vascular smooth muscle has been described in those other models of vascular injury that I mentioned earlier, like the wire stripping of the intima model that we talked about. And so you can imagine if the P-selectin is expressed on the muscle cells, or is in the vicinity of the muscle cells even, that's going to bring a lot of things into a space that normally don't see those things. There's going to be platelets in there. There's going to be activation in there. There's going to be leukocytes coming in there. And that is likely going to lead to that yellow clot, that plaque formation that I was describing earlier, potentially. And we would like to see if, in fact, that happens. And so one of the things that we looked at here in this figure is we looked to see basically 7 days out from our injury, is that P-selectin present in the media where the muscles are. And we found significantly that particularly in the area where the injury energy was greatest, the medial P-selectin is highest. And so at least on the coup side of the injury, it does look like there's an actual vascular injury that results in P-selectin being present where the muscle tissue is. And so we think that if we carry this out further than 7 days, we'll be able to see signals of actual vascular remodeling and even sort of plaque formation, things like endothelin-1 overexpression, leukocyte invasion, and a few other things like that. And so that's a pretty exciting area for us, and that's one of the areas that we're really actively going after right now. So I think I'm going to probably call it there and go through these conclusions if I'm okay with time. Last time I did one of these, I went to like 9 o'clock, and it was crazy, but I think I'm doing better today. So, so just in conclusion, pulmonary arterial thrombosis is one very different than pulmonary embolism, and the natural history of that will have some serious implications that will affect how it gets treated, the duration of treatment, and sort of the consequences of that treatment. And we know that we can inhibit it by this antibody-mediated blockade. Well, we don't know sort of what the negative consequences are of that, at least over the long term, but it does appear, at least in the acute situation, to be able to prevent that clot formation from happening. Two, when we do that blockade, it doesn't appear to have much of an impact on the overall systemic coagulation properties in our model. This is a murine model, and mice don't necessarily clot completely the same as humans. So there are steps before you can say that this is the same thing in the human. However, when you're looking at translation, one of the things that's exciting about this is that the actual reagent, P-selectin blocking antibody, has already been approved by the FDA for other indications. And so there is a drug that exists that has a safety profile that, if this actually is effective, you could directly translate clinically. Three, and I think is one of the better takeaways from this, is that our animal model of this acute thoracic, pulmonary arterial thrombosis is also potentially a model for a lot of other things, including this blunt thoracic injury, or this long-term remodeling situation, and chronic thromboembolic pulmonary hypertension, even potentially. And so that gives us a lot of possibilities for the future. Additionally, just sort of like the vascular biology and inflammation has just a lot of carryover into a lot of fields. We're always looking to see if we can get our, our anastomoses to stay open, whether we're transplant surgeons or we're doing microvascular surgery for plastics, or we're putting kidneys in, or whatever we're doing. We're trying to keep it open, or we're having vascular trauma, and we're trying to, put that vessel back together and keep that thing open without, requiring systemic administration of heparin overnight in our fresh trauma patients. And so we think that understanding the biology of how blood vessels get injured and heal actually has some very important ramifications that actually, transfer over to many different areas of surgery. So we're pretty excited about it. Also, just for your own consideration, COVID-19 is a vascular injury disease. And a lot of the same processes that you see with endothelial activation are pretty key for manifesting a lot of the complications. So some of the findings are particularly relevant. So understanding vascular biology and vascular healing is particularly important right now as we understand how to deal with some of the long-term issues in this particular pandemic. And so I'll stop there, open it up for questions. Oh, let me just acknowledge a few people. So I didn't put everybody that's in the lab that was involved in this project, but a lot of people, the key people. Currently, right now, we have Joe and Christian and Rob in there doing a lot of things. Linda Schitzman was, extremely instrumental in a lot of this, and she was a 3-time winner of the. Let's embarrass her, of the Committee on Trauma Northern California resident competition. Pete Wisner doing a lot of work. I think he's watching at home. So shout out to Pete. That's Galante. Has had a lot of intellectual contributions, and then a lot of other members of the lab. We work in conjunction with the Farmer Lab, and they help facilitate a lot of our work. And it couldn't be done without the support of the division and the department and my family, who's patient. And sometimes we get together and we eat lobster and drink different things. And then and the work was supported, as mentioned previously, by the AAST Trauma Research Award, the ASE, a Foundation Fellowship Award, with contributions by the East InvestSee program, the AAMC Grant Writers Coaching Group as well. Yeah.
Thanks, Ian. It's terrific to have within the department, particularly within the division, someone with this interest in the basic cellular biology of the disease processes that we face. The only question I had that I wanted to ask was, going back to the issue of causation of primary pulmonary thrombosis from trauma, can you have, if you were to have no P-selectin activated, can you still have pulmonary thrombosis occur?
Right. So the way that we could ultimately test that is by using the P-selectin knockout mouse. And I would say, that's a good question, and it depends where you look. As I mentioned before, the distribution of P-selectin within the lung tissue is limited to, or the larger expression is limited to sort of the mid-sized vessels. However, you could still get clot formation in the small vessels, likely, and then, sort of would that clinically manifest? It probably depend on how big your pulmonary contusion is. If it's big enough and you had a big enough small vessel injury, then maybe.
I guess the other part of it is what is the time sequence from injury to P-selectin activation to thrombosis formation? Is it a 30-second event or is it a 30-minute event?
That's a good question. I think I suspect that the endothelial activation is relatively quick. However, in order to get enough of a fibrin deposition to actually make it meaningful, that we have found takes quite a while. We don't see it within the first 6 hours. We had to sort of wait for 12 hours, at least, for us to have enough resolution of it to actually visualize it. On the molecular level, though, it probably happens really quick.
Great talk, Ian, and congratulations on a number of really interesting studies.
Thank you.
Since you mentioned transplant, at the beginning of your talk, you linked inflammation and coagulation. I'm wondering if but your interventions to reverse this process are more on the coagulation side. I'm wondering if you've tried any anti-inflammatory type interventions in your model, like something simple like corticosteroids.
We have not. So that's actually interesting because sort of the impact of steroids on coagulation versus inflammation is probably sort of opposite. And that actually would be interesting to see.
Well, I mean,
what would happen
any kind of intervention aimed at inflammation rather than coagulation, since they're so linked.
I agree, and I think that probably what you would see is that the different aspects of it as they occur are probably going to be adjusted, right? So the leukocyte infiltration and that component contributing to the pathology will probably be held back, but that's not the initial activity. So maybe the platelets show up, but then the sort of the bigger cascade doesn't happen with the corticosteroids. I mean, I would have to conjecture because we haven't done it. But I imagine it would sort of throw off the normal sequence of events there. And so I think that what we were trying to do here was find the earliest event that we could to block. Mm-hmm. And probably the earliest event would be sort of the signaling that actually causes the P-selectin upregulation. But that's a little bit more molecular than I tend to go. So I think that the P-selectin part was the earliest part that we could find. The later that you go in the process, then the more that you're going to have issues with the redundancy of other molecules and cells kicking in and being problematic. But it is an interesting question, and I'd actually be curious, sort of like intellectually, to see sort of what happens, especially with the remodeling portion of that. I think also one of the things that we don't truly know is if we do the P-selectin blockade early, what is the long-term event of that, and how would that differ than if you use steroids, right? Is it good early on but then bad later on? We don't know.
So just another quick comment. Related to lung transplant, there have been some studies looking at the ischemia reperfusion where they introduce anti-inflammatory agents via the bronchioles, airway. So I'm wondering if you've looked at any of that. Anyway, really interesting.
It is. I sort of could talk about ischemia reperfusion. The injury here is not quite the same mechanism as that, but like for example, one of the things that when I talk to the fellows about the inflammation and immunology of this is the fact that there's this whole body of literature of how Precedex decreases the severity of ischemia reperfusion injury that nobody ever talks about. I don't know why nobody ever talks about it, but I'd be curious to see sort of what happens with it. And you see a lot of the same inflammation and infiltration issues that you're talking about. And it is fascinating. And I sort of want to push a little bit in that direction too. We do think that the ischemia reperfusion and P-selectin are sort of relevant in several other areas. One of the things that that we're sort of working on also is like what happens when you place a Reboa and you occlude the aorta. Does the ischemia result in upregulation of P-selectin that then increases your complication rate distal to your balloon or not? And can you decrease the injury, for example, to the bowel with a level 1 deployment of your Reboa by blocking the P-selectin and preventing the ischemia reperfusion injury? So yeah, we've been sort of working in that direction as well.
It's 8:30, but we have a couple questions from online that I'd like to address.
So just a comment and a quick question. The first comment is from Dr. Farmer. That's a great grand rounds, Dr. Brown. You make the basic science easy to understand, and you are making a game-changing observation. The remodeling issue could be helpful for other issues. We should put together a quick multidisciplinary group to brainstorm some other ideas and models. I think Kent Lloyd can make you a P-selectin knockout mouse. The question comes from Dr. Sean Adams. Ian, there's a large variance in the P-selectin expression in the remodeling model, including a lot of overlap between injury and control. Just thinking out loud that looking for the basis of the variance could be very enlightening.
Yeah.
E.g. responder versus non-responder, omic studies or something exploratory.
Yeah, indeed. I would agree. I also think that sort of one of the first steps in looking at the variance too is just understanding what compartment dominates the response that we're seeing, whether it's the platelets, whether it's the endothelial cells or the soluble stuff, or what it is that's actually driving this. We've talked about a couple of things, particularly sort of compartment-specific knockouts with Dr. Lloyd. The idea being that maybe you can get the P-selectin not expressed by either the platelets or the endothelial cell, and sort of The more labor-intensive but quick and dirty approach to that would be bone marrow chimeras, where you took knockout mice and wild-type mice, and then you switched them back and forth, because then you could have mice that had P-Selectin expressing endothelium, but not platelet expressing platelets with P-Selectin. And you can also have vice versa by doing the opposite bone marrow transplant. And so those are sort of the things that we're looking at. Thank you.
Okay. Well, Dr. Schulzman, any last comments? You've been active in Ian's lab for several years.
My only comment would be that I do think P-Selectin is a link between inflammation and coagulation. So Dr. Perez, when he said we already are blocking inflammation by using a P-Selectin blocking antibody. And with the COVID-19 literature, one of the reasons they think dexamethasone may be helpful, the steroids, is because it downregulates.
There we go.
Boom.
Wonderful. Thank you very much, everybody. Have a good morning, good week, too. Thank you.